Thank you for joining us and for your time. We're excited to be here to have this session on time-efficient precepting, tips and tricks for maximizing efficiency while working with an LIC student. First off, I just want to thank you all so much for volunteering to do this. I know you're incredibly busy, and we hope that you can walk away with a few useful tips. I'm Vishnu Kulsekaran. I work at Denver Health and in outpatient internal medicine and am the LIC director there, along with Dr. Frank and Dr. Adkins. I'm excited to have my co-facilitators here, Dr. Deffenbacher, Dr. Frank, and Dr. Lobduska. So we have a couple disclosure slides. We have no disclosures here, and you all can earn CME credit for this time. Later, Kirsten will share in the link your opportunity to sign up for CME, and that will come in July. So when we did this session a few months ago, in the past couple of years, we used to ask, what are the first thoughts that come to mind when we think of time-efficient precepting? And we usually got a series of answers like this: impossible, exhausting, stressful. And so I definitely want to acknowledge all of those things, but hopefully help you narrow your focus and sort of help you realize that you don't have to do all the teaching all the time, and really take things on in chunks as you do this work and to make it more manageable. So our learning objectives are simple. We hope you can identify a toolbox to use to help you during busy sessions and create strategies to help your students be the most successful they can. We ask you, if you can, to try to make a commitment of 3 small things that you could start to do after going through these sessions and listening to us share our ideas and from our panel. And we'd love it at the end if you had any new ideas to share with us or other tips that we didn't discuss to bring those up, and we'll try to answer questions at the end. So why do I do this? I wanted to bring up sort of where my joy is in LIC precepting, and this was probably like the best day ever that I had when I had 3 students there on one day. But it's really, for me, it's about the relationships. It's about the longitudinal relationships I develop with my students, getting to work with them on a weekly basis over the course of the year, and what is a really formative time in their training. So that's probably the biggest thing that stands out to me. And just having a partner to take care of patients with can really go a long way. There are a lot of things that I can't do for certain patients, spending extra time with them or visiting them in the hospital or going to a visit, that adds a ton of value for patient care and really helps me and the student learn together. So sort of the pursuit of lifelong learning and co-learning is really what drives me in this work. And now I can happily say that a couple of in this picture are going to be coming back to be colleagues here. I have to acknowledge the obvious costs in teaching. You're all incredibly busy in your clinical work. I think the demands of our EHR are rising, and our time is really maxed out. So I want to acknowledge that and sort of put out there that I also recognize you're not being paid, you're volunteering to do this, and many times seeing the same number of patients. So our real hope is of small shortcuts and small tips that you can use when you're working with students. So to that end, we tried to get at what are sort of the general expectations for preceptors when they're working with students. And we know this varies by specialty and by your practice. A few years ago, we surveyed primary care faculty to try and get a sense of how many patients their students are seeing. So in general, students were seeing about 1 or 2 patients very, very early in the year. And in that early part of the year, the first couple sessions were largely could be shadowing, but then letting them see 2, and by the midpoint, maybe 3, and ending the year around 4 to 5 patients, I would say, sort of at the upper end. We found that lab follow-up or some of those responsibilities really came a bit later in the year, typically halfway through the year. and really setting expectations of what you specifically want them to do for lab follow-up and making it clear. And maybe it's just one patient that they follow up with. I think note writing can be a real value add now that we're able to use their notes. On average, students were writing about 1 to 2 notes, but towards the end of the year, as they prepare for AIs, many students are writing up to 3 and 4, and hopefully that's a real time save for you where you don't have to make a lot of modifications to their notes. So these are the topics that we're going to cover around efficient precepting, and we have a few different scenarios, and our panel is going to answer some of these questions. So setting your students up for success, expectation setting, the clinic structure, how to efficiently select patients, helping your students set time limits, exploring clinical reasoning, and just some ideas when things are too crazy or too busy, and offering authentic roles. All right. So this is our first scenario. Dr. Deffenbacher, I'm going to have you answer this, and if you could introduce yourself and where your practice is. But so you're meeting your new LIC student. It's their first week of their clerkship. So what are some key ground rules you should establish upfront to set the tone for the year?
Yeah, great question. So I am Brandy Deffenbacher. I am a family physician. I work at the A.F. Williams Clinic within the University Health System. I work with learners throughout all 4 years of the curriculum. I wear lots of different hats. So when it comes to meeting my new LIC student, there's a few things that I like to review to set them up for success. If you want to go to the next slide. So one of the first things I do is set clear expectations for the student. And so these expectations can be around, how to communicate with me or how to communicate with the student. So do they prefer text, email, phone calls? Do they want to send me a message in the EHR just to say, I'm working with you tomorrow? So really setting the expectation about how to communicate with me and when. The next piece that I do ahead of time is really describe and explain the clinic structure and workflow so that they have a general sense of how things are supposed to work and they can think a little bit more about where they can fit into that process. I also work with them, and we'll talk more specifically about this, about helping them select which patients to see. When they're first new to the clinic, they have no idea. There's a whole bunch of patients on my schedule. So really helping them identify which ones would be ideal for them to work with initially. We talk a little bit about ways that they can make clinic easier for the provider, for myself, for my team, and how they can be a team player. And again, we'll talk some more about some of these ideas. One of them is also around making them responsible for the clock. So it's really easy as a provider to lose track of time when you're in a room with a patient. But if a student is there, they can help keep you on track. And then also help them learn other ways to be efficient in clinic. And again, we'll go through some of these ideas in just a few minutes. But lastly, I think the biggest thing is setting the expectation that prior to clinic, whether that be asynchronous connection or in person, is really just touching base on how things are going. If things aren't going well, really finding time outside of clinic to sit down with each other and kind of review what's going on, how things aren't going well, and set a plan for improvement in the future. So huddle is really important kind of as the year progresses.
Great. Thank you so much, Dr. Deffenbacher. Okay, Dr. Frank, you're next. If you can introduce yourself, but we're going to fast forward 1 week in this scenario. So your student's been told during the first year that taking initiative towards self-directed learning is an expectation. They come to your clinic very eager and want to make a good impression. Although you volunteered to be a preceptor, with the new primary care templates, you're worried that keeping up with their schedule is going to be a challenge. And quite frankly, their enthusiasm is making you nervous. What can you do to clarify your expectations with the student and ensure they understand the clinic structure?
Thank you. So I'm Anne Frank. I'm a med-peds primary care doctor here at Denver Health. and lead one of the LICs here. I first kind of just would like to echo what Brandy said about huddling and making sure to huddle before each session with the student. I've had students in the past who have really wanted to know which patients that they're seeing like the day before or a little bit more ahead of time than the day of huddle. And I am not somebody who's like so ahead in life that I'm looking at my schedule days in advance. And so if that is the case, and that really helps with the student's anxiety around the session, I put the onus on the student to say, like, please text me the night before or contact me and we can pick out the patients for you to see, and then set the expectation that it's flexible and fluid. You know, the schedule may change, the patient may not show up. And so we'll huddle before the session and touch base throughout the session also. Usually in that session huddle, we identify patients together. Early in the year, I have students seeing 2 patients. And I almost always, now that the notes count, have the student write notes for the patients that they see, because that helps my workflow tremendously. I pre-round a little bit with the student around what they might be kind of touching base about, and then any heads up with communication styles or agenda setting for the patient. And then if the patient may need something that can be done between the student seeing them and me seeing them, like vaccines, I encourage the student to talk with the medical assistant. I've been fortunate to have the same medical assistant most of the time, but I'm always doing introductions if I'm working with someone new.
All right. Thanks, Dr. Frank. And I also want to echo, like, I think the huddle that Dr. Deffenbacher and Dr. Frank mentioned, I think can be really brief. It can be 2 minutes at the start of the session to just sort of touch base. And similarly, I like to have them pick patients the night before and early in the year, help them with that. Okay, Dr. Lebdeska, could you talk to us a little bit about what you do as far as organizing the clinic structure and workflow when you're working with your student?
Sure. So I'm Elena Lebdeska. I'm a primary care doc at the university. So one of the big things I think students sometimes get confused about is how outpatient medicine versus inpatient medicine works, and sort of the structure of the clinic and the workflow. So I think it's important to show them the space you actually have available to see patients, what rooms are yours, what rooms will we be seeing patients at, so they know sort of where to go and are oriented to the clinical space. Other things that are really important is to understand the flow through the clinic. So my patients show up, their visit is 7:45 in the morning. My MA rooms that patient over the first 15 minutes. I start seeing the patient at 8 a.m. and this is the time I have to see the patient, whether that's 15, 20, 30 minutes, et cetera. Helps with sort of Brandy's mention of keeping the student sort of responsible for keeping you on track, letting them know who else has to talk with the patient, not just you being involved. What happens between clinic sessions, so morning and afternoon. Maybe my MA has to take lunch at 11:30, so we have to get her out on time. What happens at the end of the day? When do labs get picked up? That type of thing. And what sort of responsibility the clinic, the student should have in clinic aside from just seeing the patient. So obviously so much of outpatient medicine happens between visits. And that's one of the nice things about the LIC and continuity is students really get to be able to experience that. So do I have to catch up on notes? What about those labs? What about the doctor that just called me from radiology? What are some other learning or clinical questions that I want the students to address aside from just seeing patients, and understanding that we're also evaluating that and that that's valuable. And then thinking about in your space, and space is always sort of an issue in outpatient medicine, where can the student really be working and part of the team that's not sucking up a room, if that makes sense? So inpatient, they can sit at the bedside of the patient for hours on end and everyone's happy about that. But is there a space that the student can leave their lunch, eat lunch, bring their computer to work, and work on patient charts that doesn't sort of take up time or block rooms for you while you're trying to see a patient maybe at the same time as a student seeing a different one?
Thank you very much for that. So a common question that comes up is just sort of, how do you organize the flow when you're working with a student as far as which patients they see? So in general, what I like to do in terms of structuring, like in the midway point through the year, is have them have a patient. I oftentimes like them to see my first patient of the day, one in the middle, and one at the end. That gives them adequate time to work on a note and gather their thoughts while I'm seeing maybe two other patients during that time. So again, I think the spacing of the patients that they're seeing, if you can space them out, is ideal. The other thing I like to do is keep direct observations brief. So when I find that I oftentimes get behind the further along the clinic goes. So I like to do my direct observation with that very first patient. So if only one patient is room, what I'll do is I'll go in the room with the student and I'll say, you talk and I type. And so I'll be their scribe. And while they're taking the history and doing their physical, I'm typing up the note, I'm putting in orders, I'm creating the after visit. So I'm not getting behind on that encounter, and then they're not having to represent to me because I've already heard them take the history. This really allows me to give them really targeted feedback along something they did in the history or physical exam that's very specific, and then move on. And oftentimes that might be the only direct observation I do for the day. So really, I think understanding that you don't have to be with your student that entire session, it's really going to slow you down tremendously if you are. So again, doing that observation up front. So I do the 2 for me, 1 for you. So I'll see 2 patients, they might see 1, and then we communicate over secure chat if they're ready for me. And oftentimes, if I'm not ready, I'll say, you know what, I need 10 more minutes. And I think being empowered to say that to your student that you need more time to catch up is okay too. Alternate or wave scheduling or some other ways to do this, but I just want to emphasize the point of being the scribe for the student. I think it serves multiple purposes in terms of efficiency and being able to give them feedback. So something to try. Okay. All right, Doctor. Let me see.
It's me.
Okay, thank you. Thank you. Thank you, Anne. Can you talk to us a little bit about how you are strategic about selecting patients for your students to see?
Yeah, absolutely. So I think depending on the student, depending on the time of the year, depending on sort of what they've seen a lot of or what they haven't seen, I like to sort of prioritize the following patients for students. So I like students to see new patients. They can spend a little bit more time than I can gathering history, tracking down records, trying to understand a patient concern. And it's a good cognitive exercise for them to be able to see somebody undifferentiated. Students obviously will follow cohort patients. And so if I'm thinking about what patients would be good cohort patients for students, I think about patients who have a lot of contact with the healthcare system, who have multiple subspecialists, who have been admitted recently or frequently in the emergency department. I think about patients who need more time to talk. In COVID especially, I had several older patients who were lonely. And so sometimes their medical visits were the only time they would be talking to people. And so I would often assign a student to those patients, both because they're medically complex and older, but also because they could use a little bit more time and they would appreciate the time to talk with a student. Patients who are going to have procedures or who are considering procedures are good patients for students. Recent ED visits or hospitalizations, patients who require close follow-up, students can make inter-visit phone calls or follow a patient in their subspecialty visits. And so that can be a useful patient for the student to see. And then if they tell you, I haven't seen a patient with CHF or COPD, then it's very appropriate to have students see patients with diagnoses that they've not yet seen. And then just a mention on what patients I sometimes avoid with students. There are some patients who won't be amenable to having the student do any part of their visit, and you know that you're going to have to repeat that whole thing. They won't sort of take the student as a history taker or the examiner, and so those are patients who I don't have students see. My patients who are more tangential or more perseverative, especially in the early part of the year, I won't have students see those patients from a time perspective.
Great, thank you. Those are great points, and I think, emphasizing to your student too that they may look up a patient or plan to see a patient, but just reminding them to be flexible, that they may have reviewed a patient, but someone cancels, they get added to your schedule. And maybe that's a great opportunity for them to kind of practice thinking on their feet or creating a differential for an urgent visit. So really, I think, as Dr. Frank said, these are all great opportunities, and really your students can learn from any patient. But I think having them not have the expectation that they need to know about every single patient, but valuing quality over quantity can be helpful for their students to prepare better for the visit, and then ultimately be more prepared to present to you. I think can make your session go faster. Okay, Dr. Duffenbacher, can you talk a little bit about, I know we've touched on some of these points, but how you help them be efficient during the visit and help set them up for success?
Yes, absolutely. So as you've heard, huddling is one of the things that we definitely encourage preceptors to use. But outside of that, there's a couple other tips. One is pre-precept. So you will review which patients they're seeing, and then work with that learner to say, hey, this patient, I saw them recently, they're here for follow-up. Here's what's going on. What do you think about that? Or here are some things that we need to touch base on with this patient. Giving them a heads up if you have a patient who is just on the more talkative side, and giving them skills on how to politely interrupt if needed, or to help guide the patient. Reminding them to agenda set, and even kind of walking through that ahead of time if it's a patient that providing advice for complex visits. So we all have those patients that we can kind of look at and we know, ooh, this is a really complex patient. Let me give the student a heads up. And we know we're going to be focusing on several things, but here's how they can prioritize that. And then for, same day sick or urgent care visits or follow-up visits, really working with the learner to think a little bit more about what their differential is before going into the room, based off of the chief concern, based off of handoff from the medical assistant, based off of their review of, if it's a ED follow-up or things like that, kind of reviewing it and saying, what is your differential? So that when they go in, they can be working on kind of their focused history and focused physical exam, which they are learning as first years, but need a lot more guidance and assistance and permission, especially as they progress through the year, to be able to do those types of skills. So along with efficiency is, how do we ensure that they can move through a visit in a timely fashion? One is really giving them the responsibility for monitoring the clock. So giving them some specific times. So that they go into the 8 o'clock patient at 8:05, and you say, okay, I want you to take 10 minutes to take a history, and then you're going to come back out. We're going to go back in, and maybe we'll present at the bedside. We'll do the physical exam together. So giving them very discrete amounts of time helps them understand what the expectations are, helps them watch the clock. You can also let the student know that you'll either send them, like if you have a EMR that allows it, you could send them a secure chat to say, hey, I'm just checking in. I'm about to come in, just so kind of time to wrap it up. or letting them know I may knock on the door and then enter. And at that point, the student can kind of wrap up what they're doing, or you can take over to kind of either just directly observe or have the student do some presentation at the bedside at that time.
Sorry for that. My connection dropped here. Brandy, would you be able to share while I fix this?
If you are able to unshare, I can share.
Thank you. Sorry about that.
No worries. Okay. So the next piece is, thinking about what are some strategies that you can resort to when things are just going really crazy, whether that's just a really hectic clinic, or that's you're coming in kind of sleep deprived for other things, for other reasons. It's like, what can you do to still make this a valuable learning experience for the learner and help you get through the afternoon or the morning? One is about modeling. So really thinking out loud for the learner. So communicating your framework for solving clinical problems. It allows the learner to really see what your thought processes are and to learn and to kind of internalize it that way. You can also demonstrate the individualized decision-making and application of evidence-based medicine to specific cases. So, involve them in looking things up and talking about, this is what I'm using here. And then also exposing them to the fact that medicine can sometimes be ambiguous, and you have to be comfortable with ambiguity and shades of gray, which some learners are more able to kind of accept that. So learning that that's part of medicine and role modeling lifelong learning. Another strategy that you can use is active shadowing. So sometimes it's okay for a learner to come in and just shadow. It's even okay to do this later in the academic year when you're like, well, but they should be seeing patients. It's okay because they will still learn from you when you are the role model there. Especially as they're later in the year, you can even ask them like, hey, I want you to be on the alert for this and give me feedback. So I want you to teach me, how did I do with agenda setting? How did I do with my, communication around this challenging subject, or what did you observe? And then bedside teaching. Don't forget that you can teach at the bedside. Most patients really enjoy being involved in that process. It makes the learning process more transparent to them. It saves you time in that you don't have to have the student present outside the room and then you come back in and sort of review that a little bit with the patient. And it also provides you that opportunity to do the direct observation, which is really the best way for a preceptor to know exactly where a learner is in their skills. And then, it also helps you to not have to teach it twice, because you may teach it to the student outside the room, and then you're going to go back in and teach it to the patient. And so you can do teaching for both the patient and the learner at the same time.
Thank you for sharing those. And I think one thing I want to highlight too is I know I do this a lot. I oftentimes rely on my same strategies and just asking yourself, have we done bedside teaching? Have we done active shadowing? And maybe even asking the student, towards the end of the year, do they want to watch you handle a difficult encounter? And more often than not, they really want to see that, how you manage those. And I've also done sort of visits in tandem where I'll take part of the history and they'll kind of jump in and we'll go back and forth. So thank you. All right, Dr. Lubduska, can you just talk about when things just are off the wall crazy, what do you do in clinic?
Yeah. So, sometimes things just suck in clinic. And I think it's really important to role model that to the student. Everything doesn't have to be perfect. Maybe you have some personal issues are going on. Maybe you have super sick patients and you're super behind and you're short staffed. So there may be a time when you just don't feel like you're going to be your best working with the student, and that's totally fine. That doesn't mean you're a bad preceptor or educator. It just means you're conscious of those limitations. So I think it's important to be honest with the student, and maybe they're having an off day too, and they can share that with you. But trying to think about what we can do instead for learning if you're not able to personally work with the student, because that's probably going to happen. Maybe you're sick for one way or the other, and we know we got to get in a certain amount of days. So how can we get students credit for that day? So thinking of who else can the student work with that day. So if you have a pharmacist, an MA, a nurse, your patient access representative, a nutritionist, a social worker, someone else that you've sort of preemptively already have a plan for. If you need to sort of tag out and tag in one of your healthcare colleagues, who would that be, and what would that sort of time look like for the patient and the learner? So as long, I think, as you set this up in advance, it really helps you out. And if you don't use it, that's fine, but you have that sort of backup when you need it. And then when things are too busy, some other options to have your student do, aside from seeing patients with you, making sure documentation is complete, whether this is finishing notes or going into the chart, taking a look at some healthcare gaps, things like that. Making sure the meds are reconciled. They could do this through a phone call with the patient, especially for our patients who are more worried about this or have lower health literacy. Why don't you teach me about something that we talked about today? Tell me why we're using fidaxomicin now instead of vancomycin for C. diff. Maybe do some reach out to especially their continuity patients, checking in, seeing how they're doing some diabetes, hypertension, mental health follow-ups that the students can talk to the patient about. You guys can make in a plan in between visits. Doing follow-ups on patients to check in and see how they're doing, if they were able to get their medications or afford it, if they're having any side effects once we start a medication. And lastly, having the students do some deep dive into charts, find things that I have missed on this patient, what is overdue. Maybe it's that colonoscopy that we ordered that never happened. Maybe they weren't actually able to get Entresto because it was really expensive, but they haven't told us that. Deeper dives into the charts for patients that are really helpful for learning when you're too busy. And then lastly, some other options here. EKG, many students have not actually done an EKG themselves or an ear lavage. I had my student do that with the MA recently, which was very exciting for them when they saw how much stuff comes out of an old person adult ear. Hasn't been cleaned in a decade. Lab follow-ups, like we mentioned. Patients are super appreciative when the students contact them. And I think the students get a lot of gratification out of getting that positive reinforcement. Oh, you checked on me. That's so awesome. And it really makes them have some ownership over their patients. Very brief presentations, 2 minutes. I love giving them a timeline set so they're not talking to me for 15 minutes on fidaxomicin, but tell me in 2 minutes about this new thing. Really communicating with the rest of the healthcare team. That's part of our evaluation of the student, how well they work with our ancillary staff. So having them be able to connect with our social worker or mental health provider, I think, is really important, and learning from them and the system. And then really trying to make sure we give some feedback between sessions to our students. How do we want them to do this, whether that's electronically? How are we going to provide feedback, making sure we sort of touch base with students and our learners.
All right, thank you for those. So we wanted to pause here and just sort of see if anyone wanted to share any ideas that they had or any challenges that they have. Feel free to unmute or put in the chat. Or if you want to put in the chat, what are 1 or 2 things you might start doing today differently, or any new ideas? We'd love to hear from you.
Hey guys, can you hear me? Quick question. So I'm new to this, and so I'm afraid maybe I haven't been doing everything like the way I'm supposed to as far as like direct observation and stuff like that. I've been sort of sending my student in and having them like see a patient, but sometimes they can disappear for a long time. And so at what point in where they're at should I be like, go do everything, go to the history, go to the physical, come back, present, and then should I be setting like, don't spend any more than this amount of time, and if they don't finish, just sort of make them stop, or kind of when should I be doing that?
That's a great question. And I think I think comes up quite often. So I think it depends is like my initial answer, but the students can go in and they've had many of them will have had time on immersions before they come to work with you, and a lot of them have done work with standardized patients before they come as part of the curriculum. So I like to observe parts of what they do to help me decide like how much trust can I give them or how much freedom can they have. But typically, like, I'm okay with them taking the history physical and taking a shot at the plan and allowing them a lot more time early on. And so, like I said earlier, I think direct observation is tough to do to really fit it in frequently in your sessions. So again, it's in short chunks, Alicia. So I would say I'm trying to think, have I seen them take a history? Do I feel comfortable with them taking a history on a common condition? And once I have that comfort level, I think it builds. But I think you'll have a sense of that based on how they're presenting and some of the questions that they have as far as independence. But let me pause there, see if you all have other ideas.
I just wasn't sure, like, is it the first couple months only have them do a history, and then after that, like at a certain time, then have them do history and physical, or like and this is probably in some presentation that you've sent out, but just to refresh my memory of sort of the timeline.
Yeah, I try to think of the year in thirds. So they're really, in the beginning of the year, they're focused on their history and physical exam in that first third. And in the middle part of the year, you're pushing them more on their differentials, and later in the year, you're pushing them more on management. It certainly is different based on the student, but that's sort of like a rough sort of trajectory timeline that we have our students kind of go through it when they're in this clerkship year. And
okay, thank you. I'm sorry, didn't mean to cut you off.
Yeah. I would absolutely echo that, and I feel like I've had students span the gamut. So I had a student several years back where we were still really working on history taking mid-year, whereas I have had my last several students already could do history taking from day one, and so we were really more thinking about their physical exam and assessment and plan earlier on in the year. And so I agree. I think you can observe, you can also get a sense from their, first couple presentations, like what their history taking skills are and where they might need to grow. And then Dr. Gil Martin asked to restate the breakdown into thirds of the year. Vishnu, do you want to go ahead?
Yeah, so typically I'd say the first third, I'm really focused on their history taking and focused physical exam. And I'll say that again, focused history and focused physical. We really emphasize that they're not taking this comprehensive history and a head to toe exam that would take way too long. So that is our focus in that first third. In the middle third, I would say is more around differential diagnosis or expanding their differentials. We're pushing them further. And in the last third, I'd say more on management. But again, like Anne said, some students are ready for that much earlier. And so it's really depends. But I would say that's kind of like the minimum level we would want our students at.
And I would say, especially in the beginning, the history is what takes the students the longest time. Because then patient brings up their toe pain and something else, and they don't know how to shut it down or move on. So I think that huddle when they're following up for diabetes, okay, I just want you to get the history about the diabetes. And then when you go in, if you have to wrap up some other short complaints, I think that's where students get really sort of bogged down. So it helps them focus on like a couple issues and rather than multiple things that most patients have.
Yeah, and I like asking my students after they've seen a patient to kind of self-assess, how do they think they did or where do they think they could improve? Because that gives me a really good sense of kind of what level they're at and what I need to do to kind of push them to get to the next level. So having them sort of reflect on how they're doing, and that can help in that kind of goal setting. And we're going to have more sessions around that in future sessions.
I just added to the chat, but we'll say out loud that I think for pediatrics, and Brandy chime in too on how you've seen this, but it does seem like it takes a little bit longer to sort of get comfortable with a well child visit and gathering history during the well child visit for all the different ages and stages. And so I would say that that generally is about halfway through the year, they've got, decent comfort with that. And then, a later in the year skill is being able to deliver the anticipatory guidance effectively for each age group.
So I see in the chat, I'll just read this out, but Mitra wrote, I really like the 2-minute presentations. Some of the students do brief presentations, which are great, and you can learn a lot as well. And absolutely, I think when you have the time, helping students identify a clinical question that comes up, something that maybe you don't know or you'd like to learn about, and have them look it up and then report that back to you, can really be a value add. The other thing I say to them too when they look things up is, sometimes it's so hard to give presentations and things like that in the clinic setting because you're just so busy, like you just need to start seeing patients. So sometimes they'll email me in between sessions and say, this is what I found, or here's what I looked up, here's the article, and here's my 3-4 sentence quick summary of it, because it can help make sure that they know how to sort of synthesize that information, and it's not taking up a ton of your time, because we all know how busy clinic is and how we fall behind. So moving some of that teaching outside of the actual clinic time with email can be helpful. If there are any other questions or ideas, feel free to put them in the chat. Brandy, can you advance to that next slide? So we wanted to close with just a couple brief tips that we've gotten from our LIC students when we asked them sort of what they want from their preceptors. And here's just a couple of them, but they do really love the opportunity for being able to be observed directly and when they're delivering the plan as well. So allowing them to summarize the plan to the patient or go over the AVS. I need this reminder too, but if you can periodically watch a physical exam, so you can ask yourself, have I seen them do an exam recently? Maybe make that a priority for that session and say, that's the one thing I'm going to really do today. Asking a student to verbalize a plan if a test comes back in a certain way, so that can help probe deeper thinking and seeing what their medical knowledge is. Allowing the student to deliver the plan in Epic and then call the patient. So this is more for lab results. So I might say, again, I would love for you to follow up on this lab result and then call the patient. And so I tell the student, I'm going to forward the result to you. Let me know what you think and what your plan is. And I'll say, great, I agree. And then they'll call the patient and create that telephone encounter. And again, the students continue to say they really do prefer that quality over quantity. So having time to write a note rather than seeing multiple patients. With that being said, as they advance and they want to be ready for their AI, they might want to take a shot at seeing multiple patients to help them get prepared for that volume. So again, checking in with your student to see what's going to be helpful for them, I think is the most important thing. And I try to make a note to myself every two or 3 months at least to say, let's check in and figure out where are your goals. And can I just remind them of what, my expectations are for them, can go a long way. So we really, really want to thank you all for your time. We know how busy you are and are so grateful for your teaching for our students. It is incredibly impactful, and you have an opportunity to really role model, outstanding patient care and professionalism. And we're so grateful for your time. So thank you all. And please feel free to reach out to any of us with questions or follow-up questions. We'd love to continue to work with you.